I am Grady Colleen in the CapeCod.com News Center, and welcome to Sunday Journal. I'm joined today by special guests from Cape Cod Healthcare, as October is Breast Cancer Awareness Month. We want to talk with some local experts a little bit more about the topic and see if we can get a little bit more information about what's going on in terms of initiatives with Cape Cod Healthcare and more. Do you mind just introducing yourselves for our listeners?
My name is Dr. Jill Oxley. I'm a breast surgeon and the Director of Breast Care Services for Cape Cod Healthcare.
And I'm Dr. Naomi Kalliath, also a breast surgeon, Dr. Oxley's partner.
Awesome. Thank you both so much for joining me for this conversation. Dr. Oxley, Dr. Kalliath.
Thank you.
Thanks for having us.
So we want to start with Dr. Oxley. Can you tell us a little bit more about how many people may develop breast cancer, either locally, nationally, just any scale to give us a rough idea of how many people are impacted?
So breast cancer is the most commonly diagnosed cancer in women in the U.S. and the most commonly diagnosed cancer in the U.S. overall. The American Cancer Society estimates that this year, approximately 297,790 women will be diagnosed with invasive breast cancer, and over 55,000 more will be diagnosed with non-invasive breast cancer. In Massachusetts, that translates to about 6,770 invasive cancers, or roughly 1 in 8 women will develop breast cancer in her lifetime. And so when you think about that in terms of the national incidence, for every 100,000 women in the U.S., over 128 will develop breast cancer. But in Massachusetts, we are higher than average at 134. And in Barnstable, we're actually the second highest county at 154.
Should men also be concerned with breast cancer?
Well, I wouldn't say concerned, but aware.
Mm-hmm.
About 1% of breast cancers each year are diagnosed in men, so roughly 2,800 new breast cancers will be diagnosed in men this year. But instead of the 1 in 8 risk that a man has, that's more like 1 in 833.
Mm-hmm.
So a man's risk is much lower.
Mm-hmm.
But a man's risk of breast cancer can be increased if he has a family history, if there are any genetic mutations in the family, if he had chest radiation, or if he either took drugs containing estrogen or has a medical condition that causes an increase in his estrogen levels.
Mm-hmm. So early detection has been stressed as vital. Can you elaborate on how that impacts treatments and going forward, the outcomes, essentially?
So diagnosing a cancer at an earlier stage is going to lead to the highest rates of cure.
Mm-hmm.
Screen-detected breast cancers tend to be more favorable than breast cancers that are diagnosed in women who don't have regular screening, or those that are diagnosed in between regular screenings. And the stage at diagnosis is related to the survival. So a cancer that's diagnosed at an early stage is limited to the breast, and then a slightly more advanced would be limited to the breast and the lymph nodes in the region, and then a more advanced cancer would have spread to other organs. And so with screening, we're able to detect over 2/3 of breast cancer limited to the breast, and over 90% limited to the breast and the lymph nodes. And so when a breast cancer is diagnosed at stage 1, the 5-year survival from that is about 99%. So women are going to do very well. Whereas if it's stage 2, it's still got an excellent prognosis at 93%. That drops to 79% for stage 3, 75% for stage 3, and 29% for stage 4.
Mm-hmm. Now, what kind of detection methods are available? We have 3D mammography, considered the gold standard. Do you mind elaborating a little bit more on these options?
Sure. So mammograms are the only screening tests that have been shown to decrease deaths from breast cancer. 3D mammography, which is also called digital breast tomosynthesis, has been shown to detect cancers at higher rates and lead to lower recall rates than 2D digital mammography. Mm-hmm. And this 3D or digital breast tomosynthesis is especially helpful in women with dense breasts. And so breast density actually falls into 4 different categories. They call them A, B, C, and D. And roughly 10% of women fall into category A, 40% in B, 40% in C, and another 10% in D. So roughly half of U.S. women have dense breasts and half don't. And so women who have dense breasts can benefit from 3D mammography. Also, women with dense breasts may benefit from additional screening, such as an MRI, especially if there are other risk factors involved. And then for someone who has an abnormal mammogram, additional diagnostic imaging may be used, and that can include ultrasound as well as MRI.
Mm-hmm. Can you talk a little bit more about how often someone should get a mammogram?
So if a woman is at average risk, there are different guidelines out there, but Cape Cod Healthcare follows the guidelines established by the American College of Radiology, Society of Breast Imaging, American Society of Breast Surgeons, as well as the National Comprehensive Cancer Network. And those guidelines recommend annual mammography starting at age 40 and continuing as long as a woman is in good health and has a life expectancy up to 10 years. But if a woman is at higher than average risk of breast cancer, she should be offered supplemental screening as well, and that can usually include an MRI. And screening for high-risk women can start as young as age 25 with MRI screening, as young as age 30 for mammograms.
So can you tell us about breast self-awareness? What should people be looking for if they're doing self-exams, and if they are a younger individual?
So breast self-exam means knowing how one's breasts normally look and feel, so that if something changes, they can let their healthcare provider know. And a lot of groups have replaced breast self-examination with breast self-awareness, because the self-examination implies a routine inspection of one's breasts looking for cancer. And there's not a lot of data that has actually supported that. However, there's lots of studies that have shown that women have detected their own breast cancer in rates between 43 and 71%. So being self-aware means looking for changes in size, shape of the breast, skin discoloration such as redness, skin dimpling, nipple discharge, as well as new lumps. And all women should be self-aware. So age 18 and up, everyone should be aware of how their breasts normally look and feel. And then starting at age 25, they should have at least an annual or every other year clinical breast exam.
Mm-hmm. All right, thank you very much. As well, Dr. Kalliath, why is it important to know one's breast cancer risk? What guidelines do you recommend for when it comes to having a formal risk assessment?
Yeah, that's a great question. So we know that, as Dr. Oxley said, 1 in 8 women gets breast cancer, and so that's about 12% lifetime risk. We in the medical community have basically a cutoff. When somebody's at a higher risk of breast cancer, we deem them to be quote-unquote high risk if they have a lifetime risk of 20% or greater. So it's important to know that, because if you have that increased lifetime risk, then you can potentially qualify for heightened screening. So the annual mammogram is a baseline recommendation for everyone, including those at average risk. But when women are at this increased lifetime risk over 20%, then they could qualify for breast MRI, plus a clinical breast exam, sometimes genetic testing. So yeah, it's important to know.
Mm-hmm. Speaking of genetic testing, do you mind talking a little bit more about how family history can play into this?
Yeah, so family history plays a strong role in putting someone at risk for breast cancer. That being said, even though we know that, having a first-degree relative or other relatives who have breast cancer puts you at a higher risk, most of breast cancers are not hereditary. Less than 10% are actually hereditary. So I have women regularly, we both have women regularly who come to us with their breast cancer diagnosis, and they're shocked because, they say, I don't have a family history. I don't understand how this happened. Well, it's common. Mm-hmm. Yeah.
So as well, we wanted to talk a little bit more about how lifestyle might play into this. Can you elaborate more on some of the choices that we can make in our daily lives that might have increase or decrease the risk factor?
Yeah, absolutely. So we know that risk factors for breast cancer not only include the family history. We know that early menarche, like getting your period before age 12, late menopause after 50, no prior pregnancies, any tobacco use, excessive alcohol use, obesity, plus the family history. All of these things can increase your risk factors. So it's important to know if any of these are, in one's lifestyle or their history, but some things are in our control. We call these modifiable risk factors. And so our body weight, for instance, we know that improving your body mass index or your overall body weight and increasing your exercise, if you can get 5 days per week of exercise, that reduces the breast cancer risk by 30 to 35%, which is very significant. Mm-hmm. And it's great, but it still does not replace getting your screening mammogram. So that's one thing that I want to make sure is a driving point from today. Because as Dr. Oxley said, that catches cancer early, and that's the best way that we can treat it and get people cured.
Mm-hmm. Now, so before we move on from the family and the genetic component, I did want to ask more about why family members might be included in genetic testing. Can you just talk a little bit more about that for us?
Yeah. So first of all, just to explain genetic testing is where one either spits in a tube or gets their blood drawn. It's a one-time test, and the testing basically determines if there's any mutation or essentially a trigger in that patient's DNA that puts them at higher risk for breast cancer. And so the NCCN, or the National Comprehensive Cancer Network, recommends that anybody who has a new breast cancer diagnosis, if they have that diagnosis at 50 or younger, they qualify for genetic testing. If they have multiple primary breast cancers, they are a male with breast cancer, if they have any Ashkenazi Jewish heritage, then they qualify for genetic testing. Certain types of breast cancers qualify for genetic testing. And then if you have a strong family history of certain breast cancers, including breast and prostate, all of these qualify a patient for genetic testing. The American Society of Breast Surgeons put out a recommendation that anybody with breast cancer qualifies for genetic testing. So we certainly consider it for all of our patients who have that new diagnosis. And then for people who don't have the breast cancer diagnosis, sometimes genetic testing is still implicated if they have a first or second degree relative who fall into the categories that I just mentioned. And then other people who come and have a formal risk assessment and they're at this elevated lifetime risk of breast cancer, they can also qualify for genetic testing as well.
All right. Now, so Dr. Oxley, if someone is identified as high risk, what are the next steps? Can you talk more about the programs through Cape Cod Healthcare?
Absolutely. So people become high risk different ways. So they may have already had a formal risk assessment. They may have had a routine mammogram that calculated this risk score that Dr. Kalliath was referring to, greater than 20%. They may have had genetic testing, or they may have had a breast biopsy that puts them in a high risk category. And so if they haven't already been seen at our clinic, Dr. Kalliath, myself, and our nurse practitioner can see these patients and do a thorough risk assessment, including a review of imaging and a clinical breast exam. And then moving forward, there's different parts of high-risk screening. So the imaging screening we both talked about earlier, every woman at average risk should be having a mammogram starting at 40. But we want to make sure that these younger women who are high risk are starting at the appropriate imaging. A typical high-risk screening schedule would be alternating mammograms and MRIs, one then the other every 6 months. These women should also be having a clinical breast exam once or twice a year. And then depending on the degree of risk, a lot of women are candidates for risk-reducing medications. We call that chemoprophylaxis. That can reduce the risk of developing breast cancer about in half. And then for the highest risk women, they may wish to pursue risk-reducing mastectomies or removing the breasts, and that can reduce their risk of breast cancer by about 90%. And so when the patient does get referred to our clinic, we come up with the most appropriate plan and then follow them at least annually.
All right. Now, as well, if a breast cancer diagnosis is confirmed, just for people, can you talk a little bit more about what the next steps are after there's been a confirmation? Who is involved in the process? For the essentially the journey that's going to be following.
Absolutely. So we have a team approach to breast cancer at Cape Cod Hospital. Now, most patients who are diagnosed are going to see her breast surgeon, his or her breast surgeon, as the first physician after diagnosis. When they come to see us, they meet with our certified breast patient navigator, and she will help guide them through all of the steps. And so there may be additional imaging that's required after diagnosis. There may be other referrals that need to be placed at the time of diagnosis, or their next step may be surgery, and so our navigator coordinates that. Most patients then will be referred to medical and radiation oncology after surgery, but some will be referred before. And every newly diagnosed breast patient at Cape Cod Hospital and Cape Cod Healthcare is reviewed at a weekly conference. Cape Cod Hospital, we have our weekly multidisciplinary breast cancer conference, where we have representation from breast surgery, plastic surgery, radiology, pathology, medical oncology, radiation oncology, the patient navigators, research, and social work.
Mm-hmm. Thank you very much. Dr. Kalliath, what are some of the other resources that Cape Cod Healthcare provides who may may develop or have developed breast cancer?
Yeah, so we have a lot of great resources. We have the Cape Wellness Collaborative, which is an awesome group that basically helps these patients, these people who are facing their new cancer diagnosis feel better, and they offer a lot of services. They have acupuncture and massage and yoga, events. Sometimes they will help provide meals to patients who are going through this, or help fund certain aspects of care. We have a monthly support group that's headed by the nurse practitioners on the imaging side of our outpatient clinic, the Cuda Breast Care Center at 35 Wilkins. We have therapy dogs, we have social workers, case managers, financial counselors, genetic nurse practitioners. We have an awesome group of folks to help support patients as they get through this diagnosis.
Mm-hmm. Can you elaborate more on we've heard about a survivorship program as well. Can you elaborate for us?
Yeah, for sure. So the survivorship program provides emotional and psychological support to a patient and their family. There's education, a lot of education about cancer. There's individual counseling that can be offered. We also have an oncology nutrition program with dietitians, and they can also give information on the Cape Wellness Collaborative. We have rehabilitation services. We have a program called Living Fit for You, which is a wellness program that basically promotes health through fitness. And then we have programs through the American Cancer Society as well. We have events. The weekend before last, we had the 9th annual survivorship event. We had over 200 attendees there, which is awesome. So yeah, there's a lot that the system has to offer.
All right, awesome. So we're about coming up on time, but I wanted to ask a little bit more about some of the initiatives or campaigns that might be ongoing, because it is Breast Cancer Awareness Month with Cape Cod Healthcare. Can you elaborate a little bit more about what we can expect in terms of initiatives?
Sure. Yeah, so for this, I would direct you to a website, which I will read. It's www.capecodhealth.org/breast-care. And there's a variety of resources there, including the ability to self-schedule a mammogram via MyChart patient portal, which is great, and then also to take an online risk assessment, which can help people determine if they should come in for a formal risk assessment. And if anybody is ever questioning if they're at high risk, if they're thinking, I have some family history, or I got my period young and I haven't gone through menopause, I'm 55, all of these things, then just make an appointment and see if you're at high risk with any of us. It's, Dr. Oxley, myself, Dr. Kalliath. We have a nurse practitioner, Stephanie Ellis, who does these risk assessments as well. So,
all right, awesome. For our listeners as well, we will have that link in the description on capecod.com. We are about wrapping up on time, though, but while I still have you, is there anything else that either of you wanted to relay to our listeners while we're still in the studio? Dr. Oxley? Dr. Kalliath?
Get your mammograms, get your risk assessment.
That's what I was going to say. I second that. Ditto.
All right, awesome. Thank you both for joining me for this conversation.
Thanks
Thank
for
you for
having
inviting us.
I'm Grady Collane in the CapeCod.com News Center, and this has been Sunday Journal.